Columbus events in our fall lecture series. And I would encourage those of you who haven't done so already to take a look at our other events. Next week, for instance, on October 22nd at 5:30, we'll be hosting columnist Roy Murdoch, who will discuss the debt ceiling debate, a very timely topic. And the following week, on Monday, October 28th, over at Buey-Amici, we will have Dr. Devine, the director of OSB Reagan, who will discuss his new book, America's Way Back, a discussion essentially about whether conservatives and libertarians can get along. For those of you in the room who are not familiar with the Buckeye Institute, I'm proud to be the president of that organization, which is the premier free market public policy think tank in Ohio. In that capacity, we attempt to devise free market solutions to the most pressing public policy problems and questions facing the state. And I'm proud to say that we've been on the forefront of the question about whether to expand Medicaid and how to address healthcare issues in the state. To that end, if you have not already done so, I would commend to your attention the numerous papers that we have at the registration table. Please feel free to take those, or visit us at buckeyeinstitute.org where you can download that material. Tonight, I'm pleased to present to the audience a presentation on the question of Medicaid expansion. And this is a question that, as the legislature has grappled with it, and the governor has proposed the expansion, that has raised a number of ancillary questions. What is the thing we do in terms of garnering flexibility from the federal government in terms of how it is it would operate the program? Can we have work requirements? What is a waiver? And what does it take to get one? Down to what is the federal plan amendment? And to what extent are we binding ourselves in the long term by modifying the existing state plan? When these sorts of questions are asked, it's good to go to experts. And I'm pleased to say that we have the foremost experts in the country on these questions, the very people who have administered the program at the federal level with us today. First up will be Paula Stannard. Paula is the former Deputy General Counsel and Acting General Counsel of the U.S. Department of Health and Human Services, where she oversaw the Food and Drug, Civil Rights, and Legislation divisions of the 450-attorney HHS Office of the General Counsel, and provided legal advice and counsel to senior HHS officials, including the Secretary of the Department, on the issues arising in the respective areas. At the firm of Alston and Bird, Paula advises clients on regulatory questions that arise out of the ongoing healthcare reform effort and focuses her practice on HIPAA and health information technology, food and drug, and other regulatory issues in the healthcare sector. Her HHS experience provides clients substantive knowledge of and experience in FDA, HIPAA, e-health, and health IT, federal health insurance regulation, patient safety, and public health preparedness and emergency response. Paula received her law degree from Stanford Law School in 1990, where she was an executive editor of the Stanford Law Review, and her BA magna cum laude in political science and Latin from Amherst College, where she was elected to Phi Beta Kappa. She clerked for the Honorable J.L. Edmondson on the United States Court of the 11th Circuit, a fine judge. Please join me in welcoming Paula Stannard.
Thank you. Just a quick disclaimer. The views I'm going to express today are my own views. I may be advising clients on some of these issues, but anything I say are only my views and don't necessarily represent the views of my clients, either my former clients at HHS or my current clients. With that understanding, I just want to talk briefly about the statutory regulatory structure of the Medicaid program, and then turn to Dennis to talk about the practicalities and operating programs. And I want to start by admitting that the ACA fundamentally changed the nature of the Medicaid program. state Medicaid programs are structured around state plans or waivers, which CMS has to approve in order for the state to receive federal funding for the Medicaid program. Now, prior to the ACA, there were 4 categories of mandatory populations that had to be covered. The elderly poor, people with disabilities, the blind, members of families with dependent children, that type of population up to a certain percentage income, certain income as a percentage of the federal poverty level. There were also some optional populations that states could elect to cover. The ACA changed that and now requires that, or proposes to require that Medicaid cover all non-elderly, non-pregnant adults with an adjusted gross income up to 133% of the federal poverty level, or 5% income disregard that's built into the statute and regulations, 138% of poverty. Now, this fundamentally changes the nature of the Medicaid program. As Chief Justice Roberts stated in NFIB versus Elias, Medicaid expansion accomplishes a shift in kind, not merely in degree in the Medicaid program. Medicaid is transformed into a program to meet the health care needs of an entirely non-elderly population with incomes below 133% of the federal poverty line. A population of childless adults, largely young adults, but childless adults not previously covered by Medicaid. And this is, as he said, an element of a comprehensive national plan to provide universal health insurance coverage. So that's the change, the fundamental change in the eligibility requirements with respect to Medicaid. With respect to benefits package, there have been a couple of additional requirements with respect to benefits packages, but on the whole, traditional Medicaid statutorily covered a fairly generous package of health benefits. A change in 2006 under the Deficit Reduction Act gave states the option of enrolling certain Medicaid populations in what's called a benchmark plan, or benchmark equivalent packages. These benchmark packages, they cover fewer benefits than traditional Medicaid, but they are more generous in many respects than private insurance. And most Medicaid expansion populations anticipated would be enrolled in these benchmark or benchmark equivalent plans. There are certain populations that would have to be covered by traditional Medicaid, but all packages have to cover what's called under the ACA essential health benefits. Query whether some are really essential, but state Medicaid has to cover these essential health benefits in addition to everything else. But there's still potentially the requirement that because the Medicaid benefit package is broader than any particular private health insurance program, if a state chooses to cover Medicaid expansion population by subsidizing private health insurance, they would have to provide a wraparound coverage for Medicaid benefits that are not covered by the private insurance. Now, that comes to the question about what is the federal government actually paying for. There's the federal medical assistance percentage for traditional Medicaid populations. That ranges from 50%, but can go as high as 75 or 83%. Some benefits, such as family planning services, have an FMAP of 90%, and certain populations, even before the ACA, had a 100% match. With the Medicaid expansion population, these childless adults, the FMAP starts at 100% under the statute and decreases to 90% as currently written in the statute. No guarantees that will continue. So that's what the federal government pays for in terms of healthcare services. There's a different federal match with respect to the administrative costs of running the Medicaid program. The administrative costs usually have 50% federal match. There's a 75% match for certain specified administrative services, such as the operation of an approved Medicaid management information system. So the IT usually gets a 75% match if it's been approved by CMS. The operation of a Medicaid fraud control unit, 75% match for expenses. But generally it's 50%. And that is not changed with respect to the administrative expenses associated with the expansion population. There's also the issue of what requirements are imposed, for example, on Medicaid beneficiaries. For some groups, all service-related cost sharing is prohibited unless there's a special waiver granted by the Federal Centers for Medicaid and Medicare Services. And these include services provided to children under 18, pregnant women for services associated with pregnancy or conditions that can be worsened by pregnancy, Indian populations, emergency services, and family planning services and supplies. For other populations and other services, there can be some cost sharing. It's usually nominal in terms of what can be charged under traditional Medicaid. Premiums and enrollment fees are generally prohibited under traditional Medicaid. Under changes under the Deficit Reduction Act of 2006, states are permitted to impose premium and cost sharing through a Medicaid state plan amendment, subject to certain restrictions based on the level of income that beneficiaries have. But it's a limited cost sharing. So that's the structure of traditional Medicaid. There is a statutory provision called Section 1115 of the Social Security Act, which permits waivers. And Section 1115 applies to broader programs such as Medicaid, but I'm going to focus specifically on the Medicaid program. This provides broad authority to HHS to permit states to experiment and conduct research and demonstration projects that further the goals of the Medicaid program. States are required to submit a proposal outlining the terms and conditions of the proposed waiver for approval by CMS. And HHS may waive any medical requirements contained in certain specified provisions of the Social Security Act, including a requirement that a beneficiary can go to any provider he chooses, comparability, the state requirement that statewide benefit, that benefits be the same across the state. So traditionally, these types of waivers have been used to provide services to persons not otherwise eligible for Medicaid, to cover non-Medicaid services, to limit benefit packages for certain groups, to adapt programs to special needs of an area or population, or to temporarily extend Medicaid benefits in case of an emergency. There are certain restrictions and limitations on waivers. You can't limit mandatory services for mandatory covered populations and of pregnant women or children, and there's a restriction on cost sharing under waivers. An approved waiver is deemed to be part of the state Medicaid plan, and so you get federal payment for this. Although not specified in the statute, these Medicaid waivers have to be cost neutral. And under the ACA, there were a number of new requirements that were imposed on the waiver process. First of all, there's a requirement that both at the state level and the federal level, there be public participation and opportunity to comment on the proposed program that's developed by the state. The standard remains with respect to whether the CMS will grant a waiver. Its requirement is that in the judgment of the secretary, that is of CMS, whether the demonstration program is likely to assist in promoting the objectives of the Medicaid Act. That gives tremendous flexibility and discretion to the Secretary and to CMS to decide whether or not to grant a waiver. And there's an elaborate application process that has to be undertaken. There are a number of items that the application has to include, including the goals of the program to be implemented under the demonstration, expected state and federal costs and coverage projections, specific state program plans to ensure that the demonstration project will be in compliance with the Medicaid Act and its requirements, apart from those that are waived, and a process for periodic reporting to CMS on the demonstration program and for review of the project by CMS. As I said, there's both federal and state requirements with respect to public participation. Now, approval of a waiver is usually 3 years or 5 years, depending on the type of waiver. And after it's been approved, there's additional requirements for public participation. And the state has to conduct a periodic review of the project, as well as conduct an evaluation of it, because this is a demonstration project, which means that you're testing a hypothesis about what a change in the Medicaid program might do in terms of cost or providing benefits to certain populations. CMS can terminate or suspend the demonstration in whole or part if it determines that the state is not complying with the requirements of the demonstration project as approved in the waiver. Or it can suspend the project if it determines that the design of the program is not meeting the objectives that were announced for it. And I just want to, and CMS has the authority to deny funding if the state is not complying with the state plan amendment or with the waiver. This can be denied in whole or part. And as I said, under the statute, CMS has incredible discretion in terms of what state plan amendments it will grant, what waivers it will grant, and the conditions under which it will grant them. And so that's a broad overview of how, under the statute and the regulations, the Medicaid expansion would operate, and how a waiver might be obtained. That's demonstrated.
Thank you, Paul. Speaking next will be Dennis Smith, who is the Managing Director in the Washington, D.C. office of McKenna, Long, and Aldridge. His practice focuses on health policy at the federal, state, and local levels. Mr. Smith is an experienced and highly successful health policy executive, having served most recently as the Secretary of the Department of Health Services for the state of Wisconsin. Appointed by Governor Scott Walker, he was responsible for an $8 billion budget with 5,500 employees. Mr. Smith introduced a number of service delivery and payment reforms in the state's Medicaid program. In July 2001, Mr. Smith was appointed by President George W. Bush to serve as the Director of the Center for Medicaid and State Operations at the Centers for Medicare and Medicaid Services, where he served until 2008. By that time, Medicaid served more than 35 million people at a cost of more than $350 billion. During his tenure, he was the lead federal negotiator for a variety of successful waivers that redesigned Medicaid program in states including Indiana, Florida, Massachusetts, and Vermont. He led the federal efforts to expand options for states to serve individuals with disabilities in their own homes and communities, with a special emphasis on self-direction. He also served as acting administrator of CMS from December 2003 until March 2004. As if that weren't enough, Mr. Smith has also held the positions of Medicaid Director for the Commonwealth of Virginia and as Chief of Planning for the California Department of Developmental Services. He also served in the U.S. House of Representatives and U.S. Senate, where as a professional staff member on the Senate Committee on Finance, he helped create the state children's health insurance program and worked on other landmark legislation, including welfare reform and the Adoption and Safe Families Act. Throughout his various roles, Mr. Smith has worked to expand health insurance coverage and lower excess health care costs by modernizing the Medicaid and Medicare programs emphasizing market innovations, state flexibility, and individual choice and responsibility. Recognizing the challenges of demographics in the near future, Mr. Smith places special importance on the need to redesign the long-term care delivery system. Please join me in welcoming Dennis Smith.
Thank you very much, Robert. It's a great pleasure to be with all of you this evening. In both of our introductions, Robert left out one of the most important that Paula and I both have in common, which is we were both from the Midwest originally as well. So we took that Midwestern common sense approach to Washington, and that's always what makes it so interesting to, from a policy perspective. Most people, when you hear about some of the convoluted policies, it's like, that's not going to work. Just let common sense prevail and we'll be a lot further ahead. Try to make my remarks brief, but there is, starting out, no question that where we are today is not where the administration really wanted us to be. Again, as Paula mentioned, first, the Medicaid expansion was a mandate on the states, and albeit with the promise of 100% of federal, 100% federal dollars. First of all, again, sort of one of those common sense things, 100% of federal dollars. Well, what does that mean? Especially in the news these days, we know the federal government doesn't have any money of its own, right? They have to take it from somewhere, and that would be the people in this room, maybe. Do you really care whether it's paid out of your federal government pocket or your state budget pocket? It doesn't make any difference to you, really, right? You are paying 100% of the cost of it. But the administration and Congress, when they created it, again, a great breach with the past. Medicaid has been expanded incrementally, and Robert mentioned my role in the state children's health insurance program in the Balanced Budget Act of 1997, which I believe your governor was a part of at that point in time. But I often reflect, why was S-CHIP so popular and non-controversial, and the Patient Protection Affordable Care Act so controversial? And to me, I come back and, again, it's not just the match rate. The Children's Health Insurance Program had an enhanced match rate attached to that. But the key was, it was an option to the states. The states had a choice. The states had great flexibility in the design of the benefit packages, of how it would actually work. States were real partners. But along comes PPACA, and you've changed that relationship. It's no longer a partnership. It is the federal government telling the states what to do, and I think that that is why you have so much negative reaction to it among the states. Governors are problem solvers in themselves. They do not want to think of themselves as simply carrying out the federal mandates. One of the arguments that was put forth in a number of states is that if you don't expand, then that money will go to another state. That's not the way Medicaid match works. It has no relationship whatsoever to it. Whatever Ohio does has no impact on what, that money does not go down, it does not flow south. It does not go down the Ohio River. It doesn't go anywhere else. Where if you don't expand, no other state has the benefit of that. And finally, I think that again, it is a difficult decision. And you have a great deal of unmet need out there. You have a great deal of, generally states have had coalitions of provider groups come together and say, you really need to go after this money. But if a state does not expand Medicaid, there is still an expansion of health insurance coverage. Because if the state does not expand Medicaid, then an individual at 100% of the federal poverty level becomes eligible for the tax credit subsidies and purchases insurance on the exchange. So even if there is no expansion of Medicaid, the Society of Actuaries is, earlier this year estimated that in Ohio, the percentage of uninsured in the state would decline from 13.3% to 7.8%. Now again, if you are at 7.8% uninsured today in this country, that is one of the lowest uninsurance rates in the nation. So if you don't expand Medicaid, you still get down to 7.8%. Because those that are starting at 100% go into the exchange. If you do expand Medicaid, the non-group market, including the exchange, expands from about 415,000 people to 805,000 people. So again, you've got a lot of coverage. And this is one of the other things that folks have a hard time sorting out. And the administration has set a goal of adding 7 million people the first year of the exchange. Well, if they get to 7 million people, you have to first understand there are 6 million fewer people with health insurance than the start of the Obama administration. So if you get to 7, you're only 1 million more than where you were at the beginning. Secondly, 35 to 40% of the people who will become subsidized for their insurance, either through Medicaid or through the exchanges, already have health insurance. They're buying it on their own, they're buying it through their employers, they're getting coverage some other way. So again, this is a massive shift in funding from individuals to the taxpayers. But a lot of that money does not buy new net coverage. But if you don't expand in Ohio, the non-group market expands to 1 million people. Again, because we're talking about the gap between 100% of poverty and 138% of poverty. So by expanding Medicaid, you're actually taking 200,000 people out of those private sector markets in which an individual is paying a premium, which they would not pay under Medicaid, and paying cost sharing, which an individual would not be paying in Medicaid. Now, I don't want to say just if you don't expand Medicaid, words of caution before that. Fix Medicaid first. Reform Medicaid before you expand it to bring more people into the pool. And what I mean by that, Arkansas has been in the news, one of the most, has gotten a lot of coverage for their premium assistance. And if you look at their application as to why they did premium assistance, was because they didn't want to put 250,000 people into what they say themselves as an underfunded, inefficient, uncoordinated care system. And their concern was by putting more people into Medicaid, it would cost them more money because to be able to give them access to care, they would have had to increase reimbursement rates across the board. You can't increase it only for some, you have to increase it across the board. So that was a fundamental reason they chose premium assistance. And again, I would say there are hidden costs into the Medicaid program. Less so in Ohio, because you've already expanded to your parent population. You're at 90-91% of poverty already. So, but there will still be a woodwork effect of which 100% of match does not apply to them. And again, I would say you would have a reimbursement issue that you're going to face, maybe not this year, maybe not next year, but you will eventually, so people have adequate access. So how do you then meet what is the unmet need if you have not expanded? Let's just say hypothetically, a state that has not expanded, 100% above go over to the exchange. 100% below, though, is unmet need. We want people who are below the poverty level to have access to the care that they need. So then you look at who is still uninsured below 100% of poverty. Overwhelmingly, they are young. People are not going to be sicker January 1st than they are today. So their health condition is not going to change. Their utilization of services will most likely change, most definitely change, but they aren't going to be any sicker. And if you look at the studies from both the Centers for Disease and Control and the Agency for Healthcare and Research, AHRQ, Quality and Research, you see that even people who are uninsured, majorities already have a regular place of care. They go to federally qualified health centers. They do see primary care physicians. There is a network of private and public entities out there that do provide a great deal of healthcare services. So again, to say we haven't expanded, then the conversation becomes about health care rather than health insurance. And in terms of health care, you can deliver a great deal of health care at a lot less cost than PPACA offers you. Again, because these people, the uninsured below 100% are overwhelmingly young. And the health care that a 25-year-old uses, for example, really isn't going to change very much. They go to the emergency room. They go to the emergency room because they've had an accident. After they get covered, they will still go to the emergency room because they went to the emergency room for an accident. They're not receiving basic health care there. Also, we know 20 states already. Again, a lot of this is not new. It's already been tested. We've already had experience, but I don't think Washington paid too much attention to it. At least 20 states, either with state-only programs or through waivers, including waivers that I approved when I was at CMS, and a waiver that Wisconsin had before I got there, served the very population that we were talking about. And again, we know from that experience, it's people with healthcare problems are the ones who actually show up and enroll. The idea that the young immortals are going to flood into the market and balance all of this out is simply not consistent with actual experience of the states. And again, 20 states is a pretty good sample, and they're very diverse states as well. In Wisconsin, what we saw in particular was, again, the rationale we've been told is the use of emergency rooms will go down, and so it'll be lower cost to help pay for the expansion. The actual experience was the opposite. Utilization of emergency rooms went up, not down. Again, in many respects, they also were not using all of the preventative services that have been added into the essential benefit package that Paula mentioned. People will go to their doctor for their well care. They'll get their preventative care services that we want them to have. And that, again, will keep them out of the emergency rooms. That is not the experience that we actually had. We also, again, when you're looking at Medicaid in particular, Medicaid is, simply stated, the cost per person that you're counted, and that is based on their utilization of services, and then the number of people that are on the program. So again, Medicaid is already, Robert mentioned when I started there, 35 million people. When you add in the CHIP program, the kids, you're about 40 million, 42 million. Medicaid is going to grow to 80 million people are going to be on the Medicaid program. And again, the idea that you can flood that many people into the system and not overwhelm it is going to be a real challenge. But in terms, again, of the message that states need to be thinking about is, first, one of the most important solutions is to get people back to work. Medicaid eligibility is based on your income. We still are above pre-recession levels across the board, and I'm certain it is true still in Ohio. You have more people on Medicaid than you did prior to 2009. People need to be fully engaged in the workforce and get their health insurance coverage the same way as their coworkers, their neighbors, etc. That would be one of the largest solutions to the Medicaid budget. In Wisconsin, we estimated that if enrollment had simply returned to pre-recession levels, the state would say over the biennium, Medicaid expenditures would decline by $1 billion. Again, out of an $8 billion budget, or $16 billion over the biennium, you would save $1 billion simply by returning people back into the workforce and getting their income levels back up. So again, I would end with expansion is not free. The cost is going to be borne by someone. And as I said, you have the expansion itself. There are ways to meet the healthcare needs of the low-income population. But there are ways to do it other than to simply add them into a system that is struggling. Across the country, Medicaid is being paid for by taking money from somewhere else in the state budgets. Revenues are not growing as fast as the Medicaid budgets are. Revenues are not growing quickly enough to simply absorb all of the costs. You have states across the country are paying for Medicaid by taking it from public education, public safety, and other programs.
Thank you, Dennis. We'll now open up for Q&A, and I will, before I turn to the audience, I'll take the moderator's prerogative and ask each of you a question. I'll start with one for Dennis. In Ohio, as we consider these questions, one issue that's been considered is what can be done in the form of cost containment of the program, looking at per member per month and what's reasonable to anticipate in terms of cost. Can you tell us a little bit more about your experience in Wisconsin, where you did a voluntary expansion for this population? What happened in terms of emergency room utilization? What happened in terms of your costs for the program there?
Great question, very important. Again, you look at the actual utilization of the population, and we all know we have some adults already in the program. Parents, caretakers of children who are on Medicaid children. Actual utilization and cost, though, of the new population that came in under expansion were higher than the regular Medicaid population. And the Congressional Budget Office also scored that a higher cost for the new population. Why is that? Well, when you think about it, and you have to figure out who is going to come into your program, if the young people come in, your costs will go down on a per member per month basis, because they aren't going to use much healthcare services. But the people that you are certain to attract are the people with the healthcare problems. And as I said, our emergency room use actually went up, not down, even though they had access to community-based organizations and providers. When those unit costs increase, again, the other side of the equation that the federal government is looking at access, the state is going to have to increase provider payments across the board to be able to have access for the entire population. But I think that it is the most likely impact. The people who are actually going to show up are going to be older, not younger, and they are more likely to have chronic health care conditions and are more likely to become a significant user of healthcare resources.
Thank you, Dennis. My next question for Paula. You talked about the process with regard to waivers. There's been a lot of talk about potential waivers in this state. One significant issue that's come up is the potential effect that Medicaid expansion will have on workforce participation. A recent study by the National Bureau of Economic Research found that in fact, based upon the experience in Tennessee, if Medicaid expansion were engaged in nationwide, as many as close to 1 million individuals who are currently working would be incentivized to leave the workforce. This has raised questions about whether or not it would be possible to gain a waiver to do something like work requirements, co-pay, personal responsibility. There's concerns about, for instance, drug abuse within the expansion population. Can there be drug testing requirements? What is it, based upon your discussion about the discretion and the standards, can you talk a little bit about what the prospects would be for any sort of waivers of those sorts?
Sure. The first thing you mentioned was, for example, was requirements for workforce participation. That is extremely unlikely to happen. There is no provision in the Medicaid statute to impose that type of requirement. It's not one of those requirements. It's not one of those things that is traditionally considered, and there just isn't any authority to impose that type of requirement. As a result of a waiver provision. And I think you probably see significant litigation as a result of that. You mentioned issues with respect to, for example, co-pays and things like that. There is some possibility for imposition of some co-pays or cost sharing, but I think, again, that given the standard with respect to when HHS would consider granting these waivers for cost sharing, you probably are not going to see in this administration, at least, any significant cost sharing or participation that encourage responsible use of healthcare services, because the requirement is that the demonstration project, in the judgment of the Secretary, is likely to assist in promoting the objectives of the Medicaid Act, that is Title 19 of the Social Security Act. And the view in this administration is that, as amended by the ACA, the objectives of the Medicaid Act is to cover this broadened population, and it's not considered to be. There have always been restrictions on the amount of co-pays and premiums that can be charged, and I don't think that that's going to change. There's fairly specific limitations within the statute that the administration is unlikely to be able to see their way to waiving. The suggestion about drug testing, again, it's likely that an administration would view or requirement for drug testing in order to be eligible for Medicaid expansion as counterproductive to the ends that are being sought that are promoted by this change in the Medicaid Act, because this would not be meeting the medical needs of the population. If there are substance abuse issues, those issues are to be dealt with in the Medicaid program, like keeping people with substance abuse issues out of the program. And that's how it's likely to be interpreted, especially given the fact that there were specific substance abuse and mental health parity requirements that were written into Medicaid in the ACA.
Thank you, Paula. With that, I'll open it up to questions from the audience. I offer my standard caveat, which is we are looking for questions, not soliloquies. Al.
Thank you to Buckeye, of course, for bringing us certified experts to answer our questions and to give us these comprehensive overviews. What I see as I look around on this is a fight going on really at the bumper sticker level. And Dennis has already answered one of those about money that we don't take going to other states. But there are a couple more that are on everybody's mind. One is, I'll just put out a couple. One is, what is the actual hurt put on hospitals if we do this? Another one is, what is an essential benefit? Is it hip replacements every 10 years and in vitro fertilization or not?
Well, Paula probably can jump in here as well. The second part, and again, actually it's quite interesting, and the essential health benefit package, which is spelled out, there are 10 essential health benefits. And in a way, they categorize, rather than by provider default, some providers actually mentioned, others not. It's simply a category of care. People are familiar with rehabilitation. If you've broken your hip, you get to go to physical therapy, etc. That's rehabilitation. In the Medicaid world, we also have what's called habilitation, which is to maintain someone at their same level. And generally, because Medicaid is serving people with disabilities, we don't expect them actually to get healthier in that particular way, but we want to maintain where they are. So we give habilitative services. They have defined habilitative services as the same as rehabilitative services, which makes absolutely no sense whatsoever. On the essential benefit package, you mentioned in vitro fertilization. In vitro fertilization in Medicaid, Medicaid is now being required to also meet the essential health benefit package. Infertility services are generally excluded from Medicaid. There's specific in the drug program, for example, infertility services are actually excluded. But now, the ACA says the essential benefit package does include it. Our state's now going to have to start paying for the Medicaid population infertility services, in vitro fertilization, reversing sterilizations. So there's going to be a whole other, again, one of the things that I can say with certainty today, this is not settled. The benefit packages are not settled. There are going to continue to be disputes over that. I think Washington will try to continue to expand the benefit package. You have conflicts over prisoners, for example. In Medicaid, from a strict definition, the prison population would now be Medicaid eligible. But what services will Medicaid actually pay for? I think that is an incentive. States now have an incentive to say, well, we've been paying with its state-only dollars. If there's some way I can offload that into the federal government, I'm going to try to find a way. But it brings up all sorts of, I think, questions that are ripe for public discussion and debate. Do we want to, is that, for example, is Medicaid's role to pay for the health care of prisoners, for example? I think is a legitimate policy discussion that states are going to have. So,
Hospitals, what's the effect on hospitals if we do this?
In general, hospitals supported expansion with the rationale that they faced uncompensated care. I think at the end of the day, they are quite concerned now because they used, the federal government, Congress used, to help pay for the expansion. They took money out of the disproportionate share hospital program. So hospitals are nervous now. Again, they're nervous that only sicker populations are going to show up and the younger population is not. So they're going to see, they're concerned about pressure on it. I think on a state-to-state basis, they are less enthusiastic now than they were before. Especially if you understand, gee, if they go to the exchange, I'm going to get paid a commercial rate on that person who's at 101% of poverty level instead of the Medicaid rate. From a provider, which would you rather have?
And that's essentially what I was going to how it plays out, comparing the reductions in payments from the disproportionate share hospital payment program, which provided additional funding for hospitals that provided a disproportionate share of care to uninsured and low-income individuals, versus if you don't expand Medicaid, you'll have a certain population that, as Dennis said, is going into the exchanges instead of going into Medicaid. And you have Medicaid pays the absolute lowest in terms of reimbursement. Then you have the Medicare rate, and then above that is the commercial rate. So it really depends on the population that the hospital is going to be seeing.
And just one other curveball that they're facing, again, how this all plays out is going to be fascinating to watch. But what does it mean to actually be enrolled, and setting aside the problems that we know the administration has faced? But you're eligible, you've signed up, but have I actually paid my premium yet? Let's say I've paid my premium for the first month. I have to, and the second month I don't pay my premium. But under the law, you are still eligible and you have signed up. But does the health plan, if they haven't been paid, do they have to pay the hospital or not? Is a big question. So this is, as I said, it's not settled because you have a whole bunch of quirky things like this that are now bubbling up to the surface. So the hospitals are staffing up, basically, to check behind. If someone has presented their card, they're still going to be calling to make sure the premiums get paid so they don't get stuck with the bill.
Other questions? Yes.
Thank you, and I promise not to embarrass my colleagues with any questions today. But the question I have is regarding the waiver process. And in Ohio, we're looking at all the other states and what they're doing to make Medicaid reform as opposed to Medicaid expansion. Some of the things that we're looking at is Indiana's plan of health savings accounts and some things like that. And they have the waiver to do that. I know there's no guarantees in anything, especially when it comes to the federal government. But if Indiana gets it, and if we want it, is there a good chance we're going to get it? And if we're successful, is there a good chance that we're going to keep it? Or should we not trust it, not know what we're going to do? Are things going to change? How long are the waivers for? Those kind of questions.
Want me to take a shot? I actually helped negotiate the Indiana waiver from the federal side. So we started the Indiana waiver, and at that time, waivers, these are under Section 1115 of the Social Security Act. They're under the Secretary's discretion and authority. There's no right at all to a state to get a waiver. It is purely the Secretary's discretion. I would say if you've looked at Indiana's waiver, and that's something you're looking at, you need to look at the Indiana waiver renewal, which came up. CMS only approved it for 1 year. That tells you something right there. In fact, I think that tells you everything that you need to know.
Yeah, and I would add to that, as Dennis indicated, the granting of waivers and renewal of waivers is entirely in the Secretary's and CMS's discretion. And that means there's a very high standard of review if you're thinking about challenging denial of a waiver. Under the Administrative Procedure Act, an act has to be arbitrary, capricious, in violation and clear violation of the law in order for it to be for there to be a successful challenge. And an argument could be made, well, Indiana got this waiver extension. Isn't it arbitrary capricious for a new waiver not to be approved using the same type of situation? But there's a clear, because of the high standard of review and the discretion to the Secretary, the department can make a very compelling argument that there's a difference between extending a currently in place waiver and granting a new waiver. And you know, looking at the differences in the populations, in how, you know, in the change in the law between the granting of the original waiver and today, you know, it may be an uphill challenge, even if you wanted to completely mirror the Indiana experience to get a waiver of that nature approved today.
And I would also say, the administration doesn't have to say no. It's just that they never say yes. I can negotiate a waiver with you from here to eternity and debate with you over trend rates and what is budget neutrality and everything else. So, again, you would never get to court because there's no clock on 11/15 waiver. There's no deadline that the administration has to follow. As I said, they don't have to say no to you. They don't have to risk the political tension of turning down a waiver request. They just never say yes. And you cannot start drawing funds down. Do not start drawing funds down without yes.
And I'll use this opportunity to put in a commercial plug for those of you who have questions about the always say no attitude of the current administration and the standards of the Buckeye Institute put out a publication with McKenna trying to shed a little light on the waiver process, as well as some of the other issues, the inherently temporary nature of waivers and the mother may I problems of asking for renewal. Unfortunately, I'm sure we could go on for hours. Our time for this panel has expired, and I'll be the cruel taskmaster to keep us on time so that we can hear from our next panel. So please join me in thanking Paula and Dennis.